name doesn't sound like Japanese, but I'm a Japanese American. So this is how it's and I'm from St. Peter's University Hospital, which is all hospital affiliated with the Rutgers Robert Wood Johnson. So I'm also the clinical professor of the pediatrics. So that's the reason why Dr. Susan Sweat said from Rutgers. Okay. So essentially for the this may be easy to be skipped, but I just say that when talking about for the immunomodulating agent, just when thinking about how the autoimmune encephalitis develop. So it's really autoantibody is detected, both serum and CSF. That will be great. But a lot of times, in my experience, they couldn't find. So seronegative autoimmune encephalitis, I think it's present. Then how it occurs, and even process of the autoantibody production, there's a lot of cells are involved, dendritic cells, and then the antigen presentation to the usually T helper cells. Then follicular T cell have to help the B cell to make. Then who's some of the processing. So the reason why I'm talking about, because a lot of new biologics are available. And those each step of those processing, they can be blocked or modulated. So those are like kind of open the door for the new treatment measures. And I also try to say my background, I'm an immunologist and I see a lot of primary immunodeficiency patients. And the reason why I believe the seronegative autoimmune encephalitis, there's a new field with a so-called autoinflammatory disease in the immunology field. Those are like a kind of inflammasome defect or a regulatory T cell defect, either not producing or not expressing a key protein. Those patients do present with a lot of CNS symptoms, almost like schizophrenia-like pictures. Then is a lot of biologics now available for blocking each steps. So this might be like a new horizon. However, I can't explain every biologics available. So I just pick up the three common ones. IVIg, which is my, but the immunologist like a strong 40 because I'm using it more than 20 plus 30 years probably. And also the Rituximab, and also the Tocilizumab. Tocilizumab is the anti-IL-6 receptor antagonist. Then how these biologics works, I just say. Because sometimes the way that the neurologist use the IVIg seems a little different from immunologist use. And that is probably the population we deal with are different. So the little bit, but each biologics has its own side effect. So just I think it's really need to know how it works. So I start with IVIg. So IVIg, usually, you know that IVIg prepared from a pool of the plasma with a healthy screened blood donors. Usually almost like 800 to 1,000 people. Then it's old days freeze-dried, now liquid form. Then it's really process of the like a production really improved over the last 15 years. So it's really initially used as a substitution of patient with antibody deficiency, which immunologists deal with, then expanded the use of the immunomodulation. So actually the American Academy of Allergy Immunology went through all the IVIg treatment. Then what is the best supportive data? So one thing is stiff person syndrome, Kawasaki syndrome, CIDP. Those are enough data to support, not A. And my personal bias for the A is more like adjunctive treatment. Probably difficult to just control the AE, IVIg only. That's my limited experience. Okay. And so this is a production process of IVIg. So with this process, there's a lot of, used to be just IM. That's before my medical school years. And then they're just starting the different process. Then in the middle of the 1990s, there's a big outbreaks of the hepatitis C. So the additional process was added. So no more hepatitis C transmission. Then there is a kind of scare for the prion, Creutzfeldt-Jakob disease. But that was also like a preparation process. Now the risk is much low. So it really is fairly safe with regard to pathogen transmission. And if you, the IVIg is essentially coming from IgG. It's a very small contamination of the contamination of the IgA or IgM. So what you are getting of IVIg, IgG monomers. So the IgG structure is FAB antibody, it's called the antibody binding portion. And then also the FC portion is a constant region. And why I say that, because this is important for the thinking about for the immunomodulating actions of IVIg. So essentially, when it's easier to take immunomodulating actions of IVIg, so the antigen binding site, so FAB2 fraction, it's like anti-idiotic antibodies or inhibit the complement or cascade, then like stabilization C3A, C5, the complement, these are like anaphylatoxin. It's a very strong cascade of the complement activation. But I think the autoimmune condition effects of the FC portion is important. Because this is like binding to the FC. It's called the neonatal receptor, the FC receptor, neonatal FC receptor. So those are like a kind of the retaining the prolong the IgG life. Then too much antibiotic as a IVIg, actually this process are blocked. So that's one of the theory, autoantibody cleared quickly. And another one is FC gamma receptor, then antibody excess stage. So then it's really inducing the negative inhibitory signaling from the FC receptor 2B. So that's kind of the two major ones implicated with how it works. But sometimes, and also if the antibody excess condition, it really the immune complex was really more soluble. So it might be much easier to be cleared from the liver or spleen we call reticuloendothelial system. And also the other more production is really those FC receptor going to dendritic cells, then make it more like a tolerogenic dendritic cells. However, and also sometimes it works with the switching from the Th17 cells to regulatory T cells. However, sometimes this one doesn't work. Like a lupus type condition, we don't use IVIg because it's already too much antibodies, and then reticuloendothelial system is already like kind of overwhelmed by the too much circulating immune complex. So this type is actually when I was a fellow, there is some trial with the IVIg, then it's actually causing a renal damage. So the antibody excess type are too much polyclonal antibodies, probably better not to use the IVIg. So it's really case by case. I think personally, I think the CIDP type condition works well because it's just a specific antibodies. So it's easy to make the antibody excess, and then it's like inducing the negative, like inhibitory signals, FC gamma 2B. So, and I would just this is also the like a preparation for the next like a condition. When I'm talking about the T cell, cytotoxic T cells, but the T helper cells nowadays, Th1, Th17, the Th1. Then the problem is especially like a peripheral induced Treg cells depends on the microenvironment. They can go back and forth, Th7 there can be, phenotype can change the regulatory T cells. So those balances also IVIg may be affecting, but also many biologicals implicated with affecting those effector versus regulatory type T helper cell phenotype. Okay. So this is a summary of the proposed action of the IVIg. So there are so many theories, and that's how it works for in each patient. We really don't know. That is probably the case. And also that depends on the condition, there might be some side effect. So this is, so the adverse effect, it's actually a little less because the preparation of the IVIg is better. And so the immediate adverse effect is a flu-like symptom, like immunologist knows very well. And those are considered to be some contamination, the soluble mediators, like inflammatory mediators, cannot get rid of in the process of the chromatography or skin rash. Sometimes it's often like a contamination of C3A or C5A, anaphylotoxin type, arrhythmia or hypotension. And transfusion-related acute lung injury, this is a very severe one. Honestly speaking, I haven't seen it, except for the very early years when it's the HIV babies, because they are kind of full of the microbes in the body. Then giving a high dose of IVIg really is acute reactions. That's the only time I saw that. Delayed type adverse reaction, thrombotic events, that's usually the kind of the pre-existing condition, like IDP or increased viscosity, hypercoagulative. And the most common one, probably they know that is most of the people are aware neurological symptoms. Typically starting 6 to 12 hours after infusion, then it's like a subsiding almost like 3 days. But it's really varies. Some patients have the headache almost lasting like 1 week or so. Then it gradually gets better. Most of the time, this is the most significant first or second dose of the IVIg. Then it's very severe condition. It's called the PRESS, posterior reversible encephalopathy syndrome, seizures, and there's some of the palsy, transient palsy type condition can occur. And I tend to see that when the treatment-resistant seizures or some immunological condition with seizures, honestly speaking, I don't like to give the IVIg because there's almost a very high risk of the seizure clusters, I see. So those types of patients in the immunology field, we often go to sub-Q injection. Because the sub-Q injection, it really doesn't go up IgG level so high. So it's very stable IgG level. So I really rarely see the seizure complications. So those are like a kind of immunologist experience a lot. And another type of it's really, I don't see that too much, is renal impairment and hematological disorders. Then again, essentially for the high risk of those adverse reaction, essentially the too rapid, infusing too fast, then also the high dose. It's at least about 1 gram per kilo, 1.75 or 2. So the high dose. But honestly speaking, I think it really depends on the patient population. because my patient or immunologist population is a patient who has a lot of infections. So when you're starting, there's a lot of kind of the bacteria, microbes floating in the body. So that when you're giving the rapid infusion, then it's a rapid interaction of the antibody and antigens. There's an acute. I think that's personally, I feel that's the reason, that children with low seizure threshold, they have a lot of seizures. So essentially the board questions of the allergy immunology board, when you have a little bit adverse reaction, first thing is selection, slow the infusion rate. So the immunodeficiency patient, as compared to a CIDP patient, they don't tolerate the first infusion. And some of the AE patient already treated with a lot of immunomodulating agent, then already hypogamma type condition. These are patients you may have to be careful. So the IVIg still, it's really a lot of immunomodulating action, but also depends on the patient, can have a lot of side effects. So it's really have to be very careful. And a high-risk patient, my preference is subcutaneous. So there are a lot of immunologists nowadays using a sub-Q injection. So. And then going to the Rituximab. So Rituximab is an anti-CD20 monoclonal antibody, but it's chimeric. Chimeric means part of the antibody part coming from the mouse monoclonal antibody. So not all humans. And then for the CD20, it's really expressed for the more mature B cells. So good thing for the anti-CD20s, they deplete a circulating B cells, but they don't deplete already differentiated plasma cells or plasmablast or progenitor. Essentially, baby B cells in the bone marrow is not affected. So it's really transient B cell depletion, then get rid of those. So that's the reason why it's kind of doesn't cause a permanent B cell depletion. So that is one of the ways that we use. Then also they have the plasma cells, plasmablast, a very long half-life. So we don't, usually Rituximab doesn't wipe out all the antibody production. There's some exception, but that is one of the reasons why it's relatively easily usable. Okay. So the CD20 looks like this way, and the binding site is a large loop. And so the Rituximab is really for the direct binding, so inducing the direct signaling this. But also the two major action of the Rituximab's action. Rituximab is antibody. Then antibody antigen is combined. Then FC portion, remember the FC portion? That kind of changes. Then it's activate the complement. So complement-mediated cell this. Another thing is antibody-dependent cell-mediated cytotoxicity. So essentially the antibody attached to the antigen, it's a CD20, then the cytotoxic T cells activated, then make a hole. So this is perforating, and this is like a killing system happen. So this is for the, it's really, I get from the frontiers oncology. So essentially, these direct killing, I don't think so much, but it's called a CDC, complement-dependent the site lysis. Then for the complement binding, if you remember, FC portion complement binding it, then complement activation, there is a kind of make a hole, so the cell dies. Then antibody-dependent cell lysis, it's, I don't know, this left lower side is showing. And this is the mechanism of the perforating. is like making a whole, not kind of, the activated the cytotoxic T cells make a fold, then perforating get into cells, then cell lysis occurs. Phagocytosis cell death is not considered to be very major action of the rituximab. So the anti-CD antibodies for the rituximab, so that it's really see the murin variable region. It's essentially coming from mouse. So that's the reason why it has still has a good possibility, human may react to the murin part of the rituximab. So what's what? So the two conquer this type of undesired reactions. There's a new generation anti-CD20 antibodies. Now it's used for the cancer patient. Those are, it's whole human. It's essentially human monoclonal antibodies. And then the most new one is essentially these FC portion is called manipulated, defucosylated, which means fucose is like sugar molecule attaching FC portions are reduced. So that is really increasing the ADCC action. So it's much more kind of effective. So those are new things getting into the field. So essentially the B-cell depletion is because the CD20 is only expressed in the progenitor cells. So it's not really 100% effective to all the B cells. As I told you, B-cell depletion is 100% in peripheral blood. Bone marrow is not much. And also the germinal center is a lymph node. So the central memory, the B cells still left. So especially marginal zones. Then these, so the essentially the theoretically, if the memory B cells is lower, then it's really easy to wipe out, so that it's more better response. But sometimes memory B cells none in the CVID patient with this more kind of undesired side effect. I'll talk later. And then also the ITP and the lupus patient, there is a rituximab increasing Treg cell numbers. How it works, we don't completely understand, but it's one of the theories really the B cells are reduced, the B cells are depleted. And the B cells acting like antigen-presenting cells. So those the press activation signaling reducing. And then it's more combating the a tolerance type condition. That's one of the proposed mechanism in the MS patient. And then the one of the recovery for the B cells, recovery of the B cell takes a long time. Sometimes, usually I say we start seeing the recovery of the B cells 6 months. Sometimes 12 and sometimes a long time. But it really depends on the condition and it depends on the genetic and epigenetic background, I think. And the side effect of the rituximab, obviously B cells are down, so how much reducing the immunoglobulin levels, personally, I think it's most important for the infectious complications. And the late onset neutropenia is reported, then some cardiac effect, that's mild. And for immunologists, we see sometimes it's called complete depletion of the B cells and never comes back. And honestly speaking, 10, 15 years ago, rituximab was introduced to the field. Some CVID patients tried on the rituximab for autoimmune complication. But after several reports of the complete depletion of the B cells, never comes back. So that's, CVID patient, we are very careful when using the rituximab. And I have one patient with the LAB mutation. I didn't use it because But the providers, like 15 years ago, when she presented with autoimmune hemolytic anemia, it's one course of the rituximab, then it's almost more than 10 years. B cell is completely zero and never come. So I think this is associated with genetic background. And I have one patient who's a GAT65 AE patient. He has a normal immunoglobulin levels before, but it's a very severe AE. So, and it's like a status of epileptic. So it's as rituximab used. Somehow I saw in patient, that's the reason why I have the follow-up appointment 6 months later. Then they never, unfortunately, the neurologist department, they never rechecked the IgG levels or after that. So when I checked about 6 months later, his IgG was around 200, IgA and IgM non-detectable. So I was kind of, he wasn't really sick, but he's on the 3 the seizure medications, and he's probably need to go to the, so that was very scary for me, so immediately starting the supplemental immunoglobulin. So when, checking the immunoglobulin levels, checking IgG-AM, A and M is never been really wiped out, just a regular response. So you see so it's low levels, and I think this patient probably have some genetic like the predisposition, because most of the immunology patients we experience is really genetic predisposition. So but we don't have the really good markers who is respond, who don't. So at least check the B cell numbers and the immunoglobulin profile. Then 2 months or 6 months later, just check it, don't forget. So that is my experience. Then we're going to hold the Tocilizumab, because Tocilizumab is a humanized monoclonal antibody against IL-6 receptor. And then it's really the activation cascade of the IL-6 classic and trans signaling. Then it's really for the Tocilizumab was initially, it's really like a rheumatoid arthritis. When you check the synovial fluid, IL-6 is sky high. Like, serum level is normally less than 5. The joint of the rheumatoid arthritis is like 6,000 to 10,000. It's like a CRP. They go up so quickly. So that's the reason. And also the Castleman disease. So that was really, then gradually applied to the other autoimmune disease. And the Tocilizumab was tried for autoimmune encephalitis. I suspect because of the IL-6 is important for the follicular T helper cell differentiation. It's important for the B cell maturation. However, the case series reported is really 70% of the good Tocilizumab responder are seronegative autoimmune encephalitis AE patient. So the IL-6 has many different biological action. So that's kind of the, think about for the, not totally T cell targeted, not totally B cell targeted, but the other biological function sometimes very effective. So this is a kind of case why some biologics may work on the seronegative AE patient. So the production was IL-6 is coming from TLR, toll-like receptors, like infectious triggered. Okay, and then it's a signal transduction. IL-6 receptor signaling is very strange. It's not the IL-6 receptor is expressed on the cell surface, but also soluble IL-6 is can attach to the GP17. So that is called a trans signaling. So it's really strange system. So that's very unusual for the other cytokines. And effect of the IL-6, these are all from the Kishimoto's group in Osaka University. They are leading a group for the IL-6 and anti-IL-6 treatment. So the liver effect, bone marrow effect. I'm running out of time, so I just go into very quickly. Yeah. And the immune system is for the, not only working for the B-cell maturation, but it's actually the IL-6 is a major the micro-environmental factor for the differentiation of the Th17 cells, T1 cells. So the IL-6 is really effector T cell. So this is blocking for the expansion of the Treg cell profile. I thought this might be one reason it may work. Then also the vessels. It's really the endothelial cells producing IL-6, then arteritis or vasculitis. That's the reason why the anti-IL-6 was approved for the Takayasu arteritis, those like vascular inflammation. And then also works with the bones, coagulations, intestines, emotion. It's the IL-6 can induce the anxiety, depression. Then the mechanism is, I don't think I have time, but it's really, they do that, those conditions. So the IL-6 inhibition therapy like the progressed like this way. So the essentially for the, it's IL-6 has so much like acute phase reactant actions. So it's really important for infection. So when you're starting a Tocilizumab, I usually check the hepatitis B profile and consider to giving a bacterium prophylaxis, TB skin test, or TB quantiferon testing. So its screening is always important. And mild rise of the liver enzymes, usually I don't see that too much trouble. So some of the A patient, especially seronegative A patient, reportedly are responding very well to Tocilizumab. Then considering the IL-6 multiple function may not be surprising. And other type of the biologics A's, like I just quickly Voltemizumab is a proteasome inhibitor, and the low dose of the IL-2, which is expanding the Treg cells. But honestly, from immunological point of view, other Treg expander is available, like oral sirolimus, and also I like sirolimus better than IL-2 because they also enhancing the autophagy actions. Autophagy is important for the misfolded proteins, so it's really associated. Okay, so I'm sorry, I'm running out of that time. So this is for that.